Tips and tricks in corneal inlay implantation. Corneal inlays are optical implants placed in the cornea to correct presbyopia. While many inlays with different optical principles and capabilities have been developed and are being tested, the small aperture corneal inlay, also known as KAMRA inlay, has been the first to be FDA approved for the correction of presbyopia. The purpose of this educational video is to provide surgical guidance on how to insert the small aperture corneal inlay. Patient selection and planning. The most important steps in corneal inlay procedure are patient selection and planning. The candidate patient should ideally be between 40 and 65 years of age. The inlay is to be implanted in the non-dominant eye. The latter should not be amblyopic and should have a normal corneal tomography, a healthy ocular surface, a non-cataractous crystalline lens, and a normal retina. A recent trend to evaluate the optical quality of an eye, including ocular surface health and crystalline lens quality, has been to measure the eye's optical scattering using double-pass devices such as the HD analyzer. The latter provides objective analysis of the eye's optical scatter and would help the surgeon decide between a corneal versus a lens-based procedure to correct presbyopia. In the U.S., pocket creation and small aperture inlay implantation is FDA approved for emmetropic eyes between plus 0.5 to minus 0.5 diopter of spherical equivalence and up to 0.75 diopter of cylinder. The eyes can be either naturally emmetropic or post-LASIK, PRK, or any lens-based procedure. Outside the U.S., combined pocket dissection and LASIK is common practice, with some surgeons implanting the corneal inlay in the same setting, while others choosing to implant the inlay a few days to weeks later. Surgical steps for corneal inlay implantation. Corneal marking. Marking is performed over the subject-fixated coaxially sided corneal light reflex if it is very close to the pupil center, and roughly 1/3 from the former and 2/3 from the latter otherwise. It is important to mark the pocket entry incision. A good practice would be to mark the maximum central reach allowed for the incision, so it would be visible upon femtosecond laser interface applanation. Pocket creation. Clinical experience as well as available literature on corneal physiology and biomechanics indicate that the best corneal depth for inlay implantation is 250 to 280 microns, leaving at least 200 microns distance from the endothelium and at least 100 microns distance posterior from any previous LASIK flap interface. It is important to choose a femtosecond laser platform with a very small spot-to-spot distance to ensure optimal interface optical quality and minimize tissue bridges. Dissection of the pocket interface is then performed. Flap creation and excimer laser ablation. In this particular instance, pocket creation, LASIK, and inlay implantation are performed all in the same setting. Hence, femtosecond flap creation follows pocket creation. Care must be taken to ensure the flap edge stays clear of the pocket entry incision. The gentian violet marks can serve as yardsticks to stay away from during applanation for flap creation. Excimer laser ablation is performed. Then the LASIK flap is repositioned, painted over the bed, and the gutter allowed to air dry to ensure adequate reattachment. Inlay implantation. The pocket is then dissected if not done prior to the flap creation. Care must be exercised not to enter the flap interface. After dissecting the pocket interface, a dedicated forceps is used to grab the KAMRA corneal inlay, shiny side down, with the outer lip advanced to about 3.2 millimeters from the edge, just past the second pinhole rim. The inlay is advanced into the pocket, just past the corneal mark. Then the forceps is pulled back slowly to reach the circular mark. When the position is deemed ideal, the forceps is opened, left idle for a few seconds, and then it is very slowly drawn backward over about 10 to 15 seconds to avoid dragging the corneal inlay out of the desired position. In the event the inlay needs readjustment, the corneal forceps is reintroduced in the pocket, and a blunt rod or spatula is used to push down on the proximal rim of the corneal inlay while the open inlay forceps is being advanced to enhance the chances of the upper or anterior blade of the forceps to go above the inlay. Once grasped, the inlay is again advanced past the corneal marking and then withdrawn to the target position. The forceps is opened and left in place for a few seconds, then withdrawn very slowly out of the pocket.